It gives me great pleasure to invite two of my colleagues and friends, Mr. Nasir Qureshi is a consultant spine surgeon in Nottingham. He is very well published in all sorts of things, but he's done quite a lot of work in oncology. He has completed a PhD in the outcome and health-related quality of life following surgery in spinal metastasis, and continues to be very active in the research field. So Nasir, can I please call you down? We will do Nasir's talk followed by questions. We may have to let Nasir go after the questions because he is on a very tight timeline.
Good afternoon, everyone. I'd like to thank the BritSpine committee and Rajat Verma for the very kind invitation. So I'll be talking about non-compressive vertebral metastases. Do we need a pathway? Just like to acknowledge my colleagues, Lewis and Junhao from oncology, and my fellows, Hassaneen, Nikhil, and Ely, who've helped collate some of the cases. So spinal metastases, the spinal column is the most common site of skeletal mets. 30% of cancer patients will develop symptomatic spinal metastases, and 20% of cancer patients with spinal involvement will develop spinal cord compression. The MSCC guidelines published in 2008 were incredibly important, and they really helped us and helped our patients in terms of receiving timely intervention, investigations, as well as treatments, and I'm sure you'll all agree. So my PhD, 2018, this is one of the last paragraphs that I wrote, and it was sort of a prelude to sort of further research that could be done. So I wrote, spinal mets causing pain and instability are very different to MSCC. Indeed, the outcome can be really quite different. And I stated that these patients who have spinal metastases causing pain should really be studied separately to MSCC. And unfortunately, what we find in the data at the moment and in research is that all these patients are clumped together, and they are different. So how do we assess a patient with spinal metastases? So the NOMS criteria, I'm sure you're all familiar with it, with Bilski. So neurological, looking at the Asia-Frankel scoring, radiculomyelopathy, the ESC grading, which I'll come to in a second. We, of course, review the type of the primary tumor, the radio and the chemosensitivity. We assess mechanical stability using the SIN score, and we do a systemic workup for the patient, right? So we do a whole spine MRI, CTs, biopsies if needed, look at comorbidities. We use scoring systems. They still have their value. Performance status, and finally frailty. So that's more of a sort of a broad overview of how we would assess a patient with spinal metastases. So just to remind you, the ESC Scale by Bilski goes from 0 to 3. So this is all dependent on exactly where that metastatic tumor is. So 0 to 1C, probably favor radiotherapy. 3 favors some sort of decompression or separation surgery with stabilization, and then post-operative radiotherapy. And 2, the grade 2s are sort of in between. To remind you of the spinal instability neoplastic score, 6 parameters. You see the scoring system there, 0 to 6 stable, 7 to 12 potentially unstable, and 13 to 18 unstable. So using the Bilski criteria, if we have a patient with a low-grade ESCC, so a spinal metastases, there's no neurological compromise, it's a radiosensitive tumor, probably favor conventional radiotherapy treatment. If there is a low-grade spinal metastases, again, there's no compression, but it's radio-resistant, probably go towards SRS, or stereotactic radiosurgery. What about the high grades and radiosensitive? Well, we'd probably favor separation surgery. You want to create a bit of a gap between the tumor and the spinal cord, and then to be able to deliver radiotherapy thereafter. If a patient's unstable, we would go for stabilization. And of course, if unable to tolerate surgery, then radiation therapy. However, things have changed, and as new technology becomes available, the decision-making process has become quite complex. Radiation therapy does remain the least invasive option in amenable tumors to achieve tumor control and pain reduction, especially without neurological deterioration or overt instability. You'll be familiar with the sensitivity of various tumors, ranging from highly sensitive to highly resistant, and it's in this latter group that we would consider SRS, or stereotactic radiosurgery. So SRS is known as SABR in the UK, so this delivers a high biological equivalent dose in a hypofractionated regime into disease in close proximity to the spinal cord. The local control rates you will see are really very good, 87% for unirradiated, 96% for re-irradiated, and 94% for post-operative patients. So the indications for SABR are oligomets of the spine, so with controlled disease elsewhere and a pretty good prognosis of at least 6 months. Or there may be oligoprogression of that spinal metastases. There may be progression following external beam radiotherapy, and also with painful spinal mets. The inclusion criteria again, so it's got to have a good performance status, no more than 2 consecutive spinal vertebral bodies involved. Tumor ideally 3 to 5 millimeters from the cord, perhaps slightly less than that, but the criteria 3 to 5 millimeters. Histological confirmation of neoplastic disease, reasonably good prognosis, and of course, if they're unstable, then getting a spinal opinion. So oligos from the Greek means little, small, few, or scanty, and NICE defines these as 3 or less metastases anywhere in the body with spinal involvement. I think that's down to the amount of radiation that could be delivered in one sitting. Spinal oligomets are expected to become more common, earlier detection through better imaging techniques, improvements in systemic therapy, longer survival rates, and if left untreated, most patients will suffer with pain and neurological complications. The optimal dose can range from 8 to 24. We tend to favor 27 and 3, and you'll know that conventionally it's 30 and 10. The local control rates that you will see there are excellent, and pain control is also pretty good. Complications of SABR: acute, pain flare due to edema, steroids cover is necessary, acutely vertebral fractures, and late would be radiation-induced myelopathy. So, knowing what we know through NOMS, knowing what we know about the newer radiation techniques, is there an opportunity to create a new pathway? So I'm going to start off with a few examples, and we'll see how we get on. So this 57-year-old patient's got a solid metastases, it's prostate. Got multiple mets. I'm sure you will agree that it's low grade in terms of epidural spinal cord compression. VAS scores, so they're pretty high. Pain scores, neurologically intact. We rated it as a stable SINS, Karnofsky 60, and a life expectancy prognosis over 6 months. So how would we treat this patient? This is not MSCC. So it's a no or low grade ESCC. It's a solid cancer. We referred to the oncospinal MDT, and this patient went on and received palliative radiotherapy due to the multiple mets. What about this patient? So 48-year-old lady, she's got breast CA. She's undergone a wide local excision. She's had chemotherapy, axillary node clearance, is on tamoxifen. She's had a CT cap as well as a PET scan. And you can see there the lesion at L5. It's solitary. This is not MSCC. This is a low-grade ESCC with a spinal metastases, and it's an oligomets. So this patient underwent SABR. And you can see there, 3 months later, you can see the increased sclerosis. So again, same pathway, going down to the oncospinal MDT, this time oligomets and undergoing SABR. This patient also has a low-grade ESCC, a non-solid, known patient with myeloma. VAS scores range from 2 to 10 out of 10. SINS, perhaps borderline, but neurologically intact. So it's a myeloma, very radiosensitive. So it's a non-solid cancer. We passed it through our site-specific hematology MDT. Patient actually did very well with conventional radiotherapy treatment. What about this one? So again, it's a myeloma again. Myeloma referred from the myeloma MDT. He's got quite a bit of pain, chemotherapy, neurologically intact, has stable SINs. Karnofsky's 90, life expectancy 12 months. But it's a high-grade ESCC. It's a radiosensitive tumor. So we actually referred again through the MDT and actually did well with conventional radiotherapy. So this is one that I may have considered separation surgery for. If a patient does have a solid cancer causing MSCC, so neurological compromise, we would favor separation surgery and then referral to the oncospinal MDT. If it's unstable, then stabilization surgery and then referral to the MDT. If it's stable, then directly off, and unable to tolerate surgery also would be triage through the oncospinal MDT. So here, as we can see, we're sort of creating a pathway for patients that have no or very little epidural spinal cord compression versus those that actually have MSCC. Just a note about kyphoplasty and vertebroplasty. So the NICE guidelines came out for this in 2006. So I don't think they've been updated yet, but they said that this is for tumor pain resistant to conventional analgesia or radiation treatment. It has limited anti-neoplastic effect. Since then, there is actually now level 1 evidence for cementing. So this is for patients with severe pain or refractory to medical therapy, for spinal instability or potential instability, patients who have contraindications to open surgery, and could also be used as an adjunct to posterior fixation. So in order to consider patients for cementing, we look quite carefully at sort of fracture morphology. So if there isn't any significant epidural extension or cortical erosion, then yes, cementing seems very reasonable, as you see in the case on the right. If there's unstable with posterior elements, then we'd probably want to add in some sort of posterior fixation. But if there's significant epidural retropulsion, then we may consider separation and stabilization surgery. So we like to push the boundaries a little bit in Nottingham. You'll see this patient with a cholangiocarcinoma met, C2 to T1, unstable, 8 out of 10, high ASA grade. And there were some concerns with the anaesthetist about long surgeries and things. So a 6 months prognosis. So we actually did a stent, put a stent at C2, so it allows cement to stay where it should be. And when you're holding a hammer, then things often look like a nail. So then underwent cementing from C3 down to T1, and actually did really well for that prognosis of 6 months. Final note on radiofrequency ablation. So the guidelines have just been published. I've done this many years ago, trial purposes for an industry research, but there is apparently evidence for this now. So evidence on the safety and efficacy of radiofrequency ablation and then cementing. Onblock resection. So this case there you see on the right, 38-year-old, thyroid, L1, oligomets. I did this 11 years ago. Did very well. We coiled the vessels and then did the onblock. Did well. I haven't seen him, but discharged him 2 years later. But would we do this sort of surgery now? I'm not so sure. And certainly we're getting fewer and fewer referrals. It's become less with advancements of SABR. If clear margins, it's not amenable to SABR. However, you can still deliver conventional radiotherapy afterwards to sort of sterilize the surgical field, especially if there is extrinsic soft tissue involvement. The team in Oxford actually did a systematic review on Onblock resections for isolated spinal mets. They found 5 papers which fitted their criteria. You'll see the local recurrence is actually pretty low, it's 6%. Functional independence is good, 73%. High blood loss, high complication rate. Overall survival, average time 15 months with this sort of surgery. And they also say that the 5 papers had serious or critical bias. So it's still quite difficult to detect undetectable tumor deposits, and the surgery is clearly very challenging and costly. So in summary then, do we need a pathway for non-compressive spinal mets? I think we do. Spinal metastases are different to MSCC. these are complex patients. We still use the NOMS criteria. We look at performance status, prognosis, fragility scores, the importance of MDT, getting all full stakeholder involvement cannot be overemphasized. So a pathway does give us a standardized route for these patients. It gives structure to the patient's journey and allows better access to treatments. And it also does help to leverage support for the services that we provide, and we've seen that with the NICE guidelines from 2008. Thank you very much for your time.
Thank you. We'll take questions. I can start off. We've talked about this a few times before. I just wanted to ask you about access to SABR. I mean, we find access to SABR is a bit difficult because I think they have got, the SABR is used not just for spine, it's used for all sorts of other oncological measures. And how do you find it in your area, and what have you done to try and improve access to SABR?
Yeah, so I completely agree, Roger. I think most hospitals do have SABR, but it's not necessarily used for spines, as you've said. So, and also I think that's another reason why the creation of these pathways and technology and structure is so helpful. So 2008, for example, we were probably thinking about how do we get an out-of-hours MRI, how do I take this patient to theatre, but then the MSCC guidelines really helped with that, and as I said, really leveraged that support. So I think that the same sort of thing may well happen with SABR. I think you'll find that the facilities are there, but it's not applied to spines as much.
Okay, any other burning questions? Okay, thank you very much, Naz. I'm conscious that you have to be away. And now I would like to welcome Mr. Simon Hughes, who's a consultant spinal oncology surgeon. He did not have enough excitement in Manchester, so left us to go to Birmingham to get some more excitement. And he is a lifesaver several times when I've picked up the phone and say, what do I do with this? So this is mainly a back pain patient just turns up to a clinic and you find that he's got something that is really bad. Take it away, Simon.
Thanks, Roger. I've regretted it ever since leaving Manchester. But anyway, morning, ladies and gentlemen. Many thanks for the invite. I'm here today. My name is Simon Hughes. I'm one of the spinal oncology surgeons in Birmingham, and I'm going to talk about Cordoma, what not to do. I'm not sure if anyone's worried about what I have been doing with them, hence why I've been invited. But anyway, two things. Some of you will see some slides that were in a talk that I gave this time last year to Bath, so I'm sorry about repeating some of them. Second thing is, I know lunch is coming up, so I'll try and make this short and sweet, unlike my operations. I work with these three characters. We form the sarcoma, spinal arm of the sarcoma unit in Birmingham. I have no conflicts. So this slide here is a fundamental tenet of spinal oncology, and if you stick to this, you won't go wrong. It holds true at all times. Ultimately, biology is king, patient selection is queen, and absolutely everything else is just the prince. And the prince always tries to usurp the throne, but they'll inevitably fail because you cannot beat the powerful forces of the biology and the patient selection. So when we have newfangled techniques, new instrumentation, all this sort of stuff, it's great, but it's rarely going to be the panacea that you're promised at the beginning. So that sounds suitably dour, but I'll try and improve things as we go along. Right, what are chordomas? Well, these are tumours first described back in the 1850s. It's classified as a sarcoma. They are low-grade, slow-growing, indolent type tumours. They are locally invasive though, locally aggressive, and they can metastasize. Up to 20% of cases can metastasize, but typically later on in the disease process. There's a variable incidence in the literature, but typically 1 in a million, and they arise from the remnants of the notochordal embryonic cells. Hence why you see them in the midline, along the spinal axis, from clivus all the way down to sacrum. Typically they'll lie anterior to the spinal cord and the neural structures, and they make up 20% of the primary spinal tumours we see here in the UK, and probably about 3 to 5% of all the bone tumours we see, full stop. Location distribution, if you look through the literature, a lot of variability, but generally speaking, 50% are going to be in the sacrum, 35% in the skull base, or high cervical spine, and 15% in the mobile spine, so effectively top and bottom of the spine. How do they present? Well, typically in the 4th to 7th decades, which is pretty harrowing when you look around the room, because I think that covers the vast majority of us, unfortunately. There's a male to female ratio of 2 to 1, and how these patients pitch up depends entirely on the location of the tumour and how it's affecting the nearby anatomy. So craniocervical level, you're looking at neck pain, headaches, patients with myelopathic symptoms, perhaps even a CVA, pathological fractures, etc. In the sacral levels, we're looking more at low back pain, cauda-equina-like symptoms, both neurogenic bladder dysfunction, as well as a potential pressure effect from the size of these tumours within the pelvis itself, because they can often be of a decent size. The last point on this slide, though, ultimately illustrates the issue with chordomas. It's the fact they are slow-growing, leading to symptoms that typically arise far later, that means the damage is already done. And it's difficult coming back from that, hence why when I go to speak about the results, you'll see where we're coming from. So you've got a suspected chordoma, you're in clinic, and that's why Raja asked me to have this talk. What should you do? Well, without sounding like Boris Johnson during the COVID pandemic, you've got to stop, think, and stage. So what is the history of this patient? Are they dropping off a cliff just now with acute myelopathic deterioration, or is this, slow over many months and we've got a bit of time to play with? Examination-wise, what is their actual neurology just now? What is the baseline neurology? How does that compare to the neurology they had 1 month, 2 months, 6 months ago, etc.? We need bloods and medical workup as per all these tumours. You want a whole spine MRI. You want a whole spine MRI to make sure there's no obvious deposits elsewhere throughout the spine, and to check that you've got the likely correct diagnosis. CT chest, abdomen, pelvis is a must, because that's how you're going to stage the patient and ascertain whether or not there's any significant visceral load elsewhere, or indeed whether or not there's a more obvious primary kicking around elsewhere in the body. And other modalities are very useful as well at times, like PET CTs, because chordomas are typically FDG avid positive, meaning they'll glow up nicely on a scan, and if you've got any evidence of skip mets, etc., you'll tend to find them. The crux of this slide really summed up at the bottom, though. The main thing is, if you see one of these and you're concerned, the quicker you get that into an MDT, the better. And the reason is, you rely on the experience of the oncologists, the radiologists, the surgeons, everyone, in determining what this could possibly be. For me, when we speak about primary tumours, we talk about referring into specialist centres, and our sort of criteria for taking referrals is typically unusual lesions, suspect lesions, oligo lesions, diagnosed sarcoma previously, patients with a query primary bone tumour on the imaging. And the reason why we want these cases is not to take them and steal them, so to speak. It's simply due to the fact that the literature is very clear. In high volume centres, for these low incidence pathologies, the results are typically better because they are so low incidence. It also allows us to collate the data, etc., and work out where we're going, generally speaking, with these tumours, and chordoma is definitely one of them. It's not the surgical experience, though, to be perfectly honest. The vast majority of it is the radiologists, the oncologists, the pathologists, the nursing staff, all of them coming together, dealing with these tumours day in, day out, even though they're extreme low incidence in the country, and you'll get better results due to that. There's 3 things in my mind that any oncology patient has to match up, and there's 3 things that have to key in for us to move the management plan forwards. One is the clinical picture, the second one is the radiological picture, and the third one is the pathological or histological picture. And these have to key in, and radiology, pathology, clinically, we all have to agree that this is the condition we're dealing with. If you don't have that, you can really come unstuck. In order to get histological picture, though, obviously we've got to do a biopsy. Now, some of us are surgeons, some of us are physios, ESPs, etc. We all understand biopsies. But the crux of the matter with this is the biopsy is imperative. It's imperative that it's in the correct place if you have a potential for curative surgery. Because if you get the biopsy placement wrong and it's in the wrong place, you've effectively burnt your bridges potentially for cure for this patient, and it's a disaster. So that's why we always advise that the biopsies be at least discussed with primary bone tumour units, if not performed there ideally, by radiologists and surgeons who are going to be involved in the patient's treatment going forwards. The other useful thing about that is if you have FDG-avid positive disease, for instance, you look at the Cordoma lesion or the lesion suspect that you're going to biopsy, it can point you in better target areas. And ultimately you'll find that your biopsy results therefore are more successful in actually obtaining pathology. I say to patients all the time, because some of them get quite upset, understandably, when they have multiple biopsies and yet no diagnosis. You know, if there's 4 people in a room and you have a pizza and there's a single slice of pepperoni on it, then it's a pepperoni pizza. But if you split it up amongst the 4 of you, then 3 of you are getting a margarita and only 1 of you is getting a pepperoni. You know, so you've got to make sure that biopsy is in the right place and that you have the diagnosis before you move forwards. What are the histological features that we're looking at there? Well, we're looking at fossiliferous cells, which are these large bubbly cells with vacuolated cytoplasm, small nuclei. And we do immunohistochemical staining, etc. But the main one being brachyuria and S100, because that's telling you this is a chordoma and differentiating it from other types of primary tumours like chondrosarcomas. There's generally 4 main subtypes. Number 1 being conventional, makes up about 80% in our experience in the last 25 years. And then to a far lesser extent, chondroids, and we've seen some paediatric patients with this, very unusual. It's the dedifferentiated ones that are the problem though, because these are the super aggressive ones and the results will not be good going forwards, typically. So what to do if you suspect one? Well, we all, as surgeons, certainly have this reflex called the Oculobrachial reflex, which is we see something on a scan and it needs an operation, and we're all guilty of it. But that's a problem in these primary tumours, because if you plough into one or you biopsy it inappropriately, etc., you really are potentially compromising the patient's outcome, and this could theoretically be the difference between life and death. So our advice is, if you have time, which we normally do for these slow-growing indolent chordomas, bring someone in a primary bone tumour unit so that we execute the correct management plan. So now you have a chordoma, it's confirmed and it's been referred, but what are we actually going to do about it? With any tumour, generally, it's a mixture of surgery, radiotherapy, and chemotherapy. The difficulty with chordomas is chemotherapy is effectively useless. It's insensitive to most conventional chemotherapies. So surgery is really the mainstay and main option. I'll go on to speak about that, but there are 3 main types really: en-bloc, intralesional, and separation surgery. Then you've got radiotherapy, and things have evolved significantly over the last couple of decades. There we're looking at photons, protons, and carbon ions, and again I'll go on to discuss this in a while. What are we really aiming to do though? The honest answer is, if it's possible to take this tumour out en-bloc style, then that is the go-to gold standard for this patient. And for those of us who are not surgeons, what is en-bloc? Well, it's termed by Anakin back in the 70s and visited several times and adapted for spinal pathologies by Tomita, etc. But in essence, it's removal of the entirety of the tumour without violation of the capsule and hopefully encased in a continuous margin of healthy tissue. And I often speak to my orthopaedic colleagues who do oncology for the appendicular skeleton, and I look at them with envy. The simple reason is it's pretty straightforward, typically, getting margins there. Whereas in the spine, it's nigh on impossible because often these tumours are pressing up against the neural structures and significant other anatomical structures, so it's very difficult. But it is becoming increasingly possible with technical improvements, allowing us to get to the vertebral column in a full 360-degree approach. And we now also have better reconstruction techniques afterwards, so things are moving along. But just to state again, en-bloc surgery at this moment in time within the literature is recognised as the preferred treatment for local tumour control and cure of a chordoma. Patients often ask me, what does this en-bloc really mean? The analogy I give them is, you've got a water balloon buried in a foot of soil. I'm going to dig out the soil, hopefully never seeing the water balloon and hopefully not allowing it to burst. But the problem is if someone's already been in there and burst the water balloon, the cancer cells have seeded everywhere else, and that's now impossible to get out. So one of the difficulties with Onblock, well, I've alluded to some of them already, typically because of the complex anatomy, and as I've already said, these tumours are predisposed to the occurring at the craniocervical junction, as well as at the distal aspect of the spine around the sacrum, where the anatomy is quite complex. The other issue is, we talk about surgical approaches, and there's much debate in the literature. Do you go front, do you go back, do you go front and back, what is the best combination, etc. And there's been a huge evolution of techniques from Stefano Boriani, Tomita, etc. Ultimately, though, it's the pathology that dictates how you're going to take it out, as well as the surrounding anatomy. And the age-old surgical adage doesn't fail. Failing to plan equals planning to fail. So you really got to be very clear what it is you're trying to achieve and whether or not it is possible from the outset. This is an Onblock here. Obviously, it's a big specimen, and it's great to get that out. But the honest answer is it appropriate? And the questions you have to ask yourself here really is that what the tumour needed? Is that what the patient specifically here with this case needed? Is that patient medically, physically, and psychologically up to this task? And last, but by no means least, is this actually what the patient wants? This is a huge undertaking, and the studies are very clear, and we see it in our own patients. This takes 18 months to get over. It's a big operation, carries significant risks, and when we look at all the papers, we published one in Birmingham 2 years ago, the rate of complication in the lumbar spine, low lumbar spine at L5 is 50%. So it's not to be undertaken lightly. If we can't do Onblock though, because either the complication rate is deemed too high, the morbidity would be deemed too high, or the patient doesn't want it, then what can we do surgically? Well, we can go in and we can intralesionally debulk them. The equivalent analogy there is pulling a weed from the ground. Looks great at first, but there's definitely some of that weed behind, and it's going to come back. So the recurrence rate with intralesional surgery is understandably far higher. Other forms of surgery we can do are separation surgery, which the previous speaker, Mr. Qureshi, alluded to for potential stereotactic beam radiotherapy. For me, that is simply, as the slides in the previous talk showed, you've got a high Bilski, there is complication in the spinal, compression in the spinal canal. The spinal elements need to be freed up, and you need to surgically, without taking much of the tumour, but you need to take enough to get that fire break round the spinal cord, thus allowing the radiotherapists to give maximum dose and kill off as much of the tumour as possible. There's other considerations we have to take into account when we're dealing with potential surgery for these tumours though, and one of the main ones is what type of implant should we use? Should we use metallic implants, which we use routinely in degen spine, or should we be using PEEK and carbon? And the honest answer is, it entirely depends on what your post-operative adjuvant therapy is planned to be. And I'll speak about that later, but essentially, if you're going down protons, then you're really looking at having to use carbon instrumentation. So we've spoken about surgery, what's left in the armamentarium, radiotherapy. Several modalities exist, and there's been a huge evolution of techniques, but ultimately they all have pretty much the same goal, which is you use it for a curative purpose, or if it's not possible for a curative purpose, you use it post-operatively to effectively eliminate residual or subclinical lesions, reduce local recurrence, and improve the prognosis of the patient. And things have evolved considerably. Back in the day, we used conventional beam radiotherapy. That to me is like using a 12-bore shotgun to kill a tumour. It's great, but it kills everything else around it as well. And okay, we've got easy access to it. It's everywhere. It uses photons, and you can deliver up to 70 grays. But the literature is clear. You require more than 70 grays to deal with a chordoma effectively using radiotherapy. These days, we've moved on. We're now using proton beam radiotherapy. Interestingly, this was suggested way back in 1946, but actually wasn't or didn't come into clinical practice in the States until the late 1990s, and it's only been available in the UK since 2018. But what's different about protons and conventional beam radiotherapy? Well, conventional beam radiotherapy, as we said, uses photons, this uses protons, and the great thing about protons is they have this thing called the Bragg peak phenomenon. I've initially spoken to a few radiologists about this, radiotherapists about this, and often my GCS starts to fall when they start explaining it in detail, but essentially what it means is that you have this ballistic characteristic of the proton beams loaded with sharp kinetic energy, allowing more dose escalation to the precise target and limiting the exposure to the adjacent critical structures. In plain English, you're no longer using this 12-bore shotgun, you're now using a sniper rifle. So, the problem with this, though, is it requires different instrumentation. You have to use non-metallic implants, and these include things like carbon on peak. And I'm noticing Mr. Anwar grin quite considerably there, because we all know the difficulty with this, these forms of implants. And I'll show a slide in a second. But this is predominantly a problem in the cervical spine, though, because we don't yet have the technology from a peak perspective or a carbon perspective to really stabilise the cervical spine effectively enough. Sorry, just one last thing. On that proton therapy, I've spoken about the Bragg peak phenomenon. I basically just read out that paragraph. But if you look at that graph, the nice thing about the graph is essentially it shows with protons, you are maximising that dose at the tumour itself. But if you look at what we do with CBRT, by the time it gets to the tumour, the vast majority of it has gone, so to speak. Therefore, its effect is far less. This is an Onblock on the left that we've used carbon instrumentation for. You can see we've taken out the front of the spine. And this carbon instrumentation is great because if you look at that axial MRI cut, it's perfect. If you look at an MRI cut with titanium instrumentation, you'll get a lot of artifact, and it'll be extremely difficult for the physicists who are planning the protons to adequately mark out exactly where they want to zap, as you can see in the picture below. So what's the evidence for protons? Yeah, there's a lot of it. There's good evidence that it works and works well, and there's ever increasing amounts of it. Quoted 2 papers here, but there's loads. The difficulty is that the data is quite heterogeneous, and there are small numbers, which is understandable given the incidence of this type of tumour. I'd say that the short to mid-term results are favourable and certainly comparable with surgery, but the long-term results are simply not there because we haven't had it long enough, and that creates a problem. We are beginning to see anecdotally some patients who've been definitively treated with protons, i.e. no surgery, just protons, who are coming back with recurrence. And the honest answer is that presents a bit of a nightmare for us because operating now through a proton field, because surgery is now your only option, is equivalent to operating through a radiotherapy field, and it's very difficult. Increases your risks of complication for understandable reasons. Carbon ion treatment, thankfully this is just one slide because the honest answer is we don't use it in the UK. It seems to be a big thing in Japan just now, as well as parts of Germany. Carbon ions, very similar to protons. Obviously they're using carbon ions, but essentially, again, it exhibits this characteristic Bragg peak energy distribution where you can really hit that tumour hard without injuring the surrounding structure, anatomical structures. It's not available in the UK though. There are some patients who we see who will occasionally want to self-fund by going elsewhere in Europe. I think studies so far, I think it'd be fair to say from the ones I've read, suggest it's as effective as protons just now, but we simply, again, don't have the long-term results, and it remains to be seen how it does compare to protons. Chemotherapy, as I said at the beginning, it's insensitive to conventional chemo, unfortunately. There are improvements that are coming out now with molecular targeted therapies, etc., which are now being utilised, imatinibs, rifetimids, etc., and they're found to be effective to some degree, particularly in the later phases of the disease if the patient has recurrence, etc. But the patient must have specific genetic mutations for it to work, EGFR being one of them. And then, last but not least, brachyuria. If they could come up with a vaccine for that, and there's potential for one, that would be a real game changer. But I don't think we're anywhere close just now, unfortunately. So, what's the actual prognosis for these patients? Well, it's very clear that surgical resection with clear margins, i.e. en-bloc surgery, correlates very well with increased survival. If you do an intralesional, then with positive margins that is, then your risk of recurrence significantly increases. Those patients who are older, those patients who've got already metastatic disease, or those patients who've got a significant sized tumour don't do as well and have a decreased survival. And patients generally ask me, look, what is the overall survival rate, would you say just now? From looking at the literature and from our experience, survival rate at 5 years is 50% generally. If we can en-bloc it, you're going up to 65%. And if surgery is not possible, this drops to 40%. So I'm going to go through a case study, and rather than show you a lovely one that we managed to unblock perfectly and everything went smoothly, I'm going to show you a patient that she's an absolutely delightful patient. She is now 73. She calls me her pain in the neck, and I delightfully call her my pain in the backside. And the honest answer is because she pitched up in 2015 with this. And she pitched up late because she'd been seeing numerous other medical professionals, and this isn't about bashing other people, but they'd been, you know, she clearly had signs of myelopathy and was describing them, was diagnosed with bilateral carpal tunnel syndrome and chronic neck pain, etc., and eventually goes off her legs and has this scan. And if you look at that MRI, you think, well, okay, it's C3, but it's extending anterior to C4 and up beyond C2. It's in the canal as well. That's not unblockable particularly, and it's around both, not a great picture there of the axial cut, but it's around both verts. So our decision was not suitable for unblock. Let's do an intralesional, which we did. We did front and back. That's the CT scan pre-op. I did a front and back, and you can just about see on the lateral x-ray there's a cage across 3-level corpectomy. And I then said to her, right, well, you're going to have to go off for other adjuvant treatment, ideally protons, but you'll have to go at this point in 2016 to Jacksonville, Florida. And unfortunately, her husband had a terminal illness at that point, and she didn't think it was appropriate, so she went for radiotherapy conventionally. And for 3-4 years, she did quite well, and then pitched up on recurrence scans with this. And basically, on a 12-monthly basis, I go into this lady's neck. I've been in the neck anteriorly twice on both sides, twice posteriorly, to dig out as much of this as possible. And every time we're going in through a radiotherapy field, a multiple revision field, it's nothing short of a disaster. And every time I tell her this is the last time, and she pitches up in 12 months, and we do it again. And you know, we've had good results, and we've kept her on her feet, so to speak. That cage has come out twice, put it in again. The issue now is the cage is balancing on tumour at C2. And I can't do a lot more. I have done. It's given her cervical occipital. I've changed the plate, changed the cage once again, but this is last chance saloon for this. It's really unfortunate. And the reason why I put it up is not to sound pessimistic with Cordomas, but it's to point out there's this kind of perception somehow that Cordomas, and I was speaking to Hani Anwar about this, that they're slow, they're indolent, they're not that bad. They really are. They can be if they're mismanaged, and the idea of getting them to us as soon as possible is simply the best course of action. So, in summary, these are rare, they are indolent, but they're extremely challenging given where they occur at the proximal and distal aspects of the spine. Surgery with clear margins, i.e. Onblock surgery, is the go-to and gives us the best long-term prognosis. There are much improved radiotherapy modalities now available, but the long-term results are still pending. And there are exciting developments with Cordoma genetics just now, which are hopefully will give us a better understanding of the king, i.e. the tumour biology. And when we can address that, I think we'll find that things move along for these patients a lot better. So what should you do if you see one of these? Try and keep smiling. This is me. Maintain a healthy index of suspicion. Scan as quickly as you can. Do not activate the oculobrachial reflex and jump in, and refer as quickly as you can. And thank you very much.
Thank you, Simon. Any questions? I know it's lunch. I'll just ask one question. If anybody else has, please come to the microphone. Do you see that the patients are less receptive to surgery in the world of shared decision making? Do they feel that whatever life they have, they want a quality of life rather than living with neurological deficit?
I totally agree. I think a lot of it's to do with how good their internet access is before they see us. Because a lot of the time they're on, understandably, they're researching and they see things protons-wise. They see it labelled as definitive treatment. And it sounds far better than going through an operation that's going to take them the best part of 18 months to get over, with significant comorbidities. So yeah, I'd completely agree. But I think it's very clear in the literature, as I said, that surgery is currently the best option.
Thank you. Lunch, I guess, guys. Sorry for the delay. No more questions. Thank you, Simon.